Merhaba değerli arkadaşlarımız. Üreme Tıbbı ve Cerrahisi Derneği'nin yeni bir webinar programını bugün yıl sonunda başlatıyoruz. Ki bu programları yeni yılda da değişik bir şekilde belki Türkiye'de ilk defa yapılacak şekilde bizim mesleğimizde sürdüreceğiz. Geçen hafta Sayın Recai Hoca'nın moderatörlüğünde devam edeceğimiz programın ilkini gördünüz. Bu da asiste üreme tekniklerinde yenilikler 1'di. Bundan sonra ovülasyon indüksiyonunu orada görmüştük. Şimdi ise diğer bir 1'le başlıyoruz. Ustalardan konferanslar veya eksperlerden yeni görüşler diye bir programa başladık. Burada genellikle Türkiye'deki meslektaşlarımızda da konuların liderlerini içine katacağız. Ama özellikle de yani usta dediğimiz belli konunun lideri konumda olan dünyada ve ülkemizde onların da içeren webinarlara başlıyoruz ki bunlardan birini bugün sunacağız. Sevgili Recai PABUÇCU hocamızla birlikte. Buradan Üreme Tıbbı Cerrahisi Başkanı olarak da bir şey söylemek istiyorum. Tabii ki pandemi sürecinde hakikaten çok zorlandık. Sonuçta da istediğimiz eğitim programlarının çoğunu gerçekleştiremedik. Ama ümit ediyoruz ki aşılama proseslerinin devam etmesi ve korunma önlemlerinin alınmasıyla artık yıl sonuna doğru hani belki bizim umudumuz Mayıs-Haziran ayları ama yıl sonuna doğru da artık eğitim programlarını daha iyi şekilde yapacağız. Bunlardan bir tanesini slide alabilir miyim? Bir tanesini biz biliyorsunuz 1-4 Ekim'de 2020'de bir simpozyum yapacaktık. Maalesef pandemiden dolayı onu bir yönde ertelemiştik. Sonunda organizasyon komitesi bunun Nisan başında yapılmasını karar verdi ve online olarak yapacağız. Program hepinize gönderiliyor ve çok güzel bir program oldu. Biz de ilk defa böyle bir online büyük bir program yapıyoruz. Burada uluslararası katılımcılar İngilizce olarak ki burada simültane tercüme de olacak. Sizle beraber olacağız. Ümidimiz ise 29 Ekim 2021'de de 2 yılda bir yaptığımız kongremizi artık yüz yüze sosyal olarak birlikte gerçekleştireceğiz. Bunu da şimdiden size söylüyorum. Lütfen kaydedin. 4-6 Nisan ve 28-31 Ekim tarihlerinde bunları yapacağız. Hepinizi bekliyoruz. Bilgileri alacaksınız. O zaman şimdi programa geçelim. Biraz artık İngilizce'de konuşacağız burada. Çünkü bu artık İngilizce konuşmalara da alışacağız. Bakalım nasıl sürdüreceğiz. I want to thank to Professor GOMEL and also Professor Roy Homburg. We are just starting new webinar program. The name of the program is the Meet the Experts, and we are going to, repeat this program once in a month. So the experts coming from all over the world or the national leaders are going to be with us, and they are going to talk about the hot topics and give us the recent information. On behalf of myself and the executive committee of the Turkish Society of Reproduction and Surgery, it's our pleasure to have Professor Dr. GOMEL and also Professor Roy Homburg. And I'm just giving the stage to Recai Professor PABUÇCU to start with the Professor GOMEL. Recai.
Okay. Thank you, dear chair. You know, this Timur GÜRGAN is still our president of the Turkish Reproductive Endocrinology, Infertility and the Surgery Society. Değerli meslektaşlarım, ben size Viktor Hoca'yı sunmaktan çok gurur duyarım. Biliyorsunuz o reproduktif cerrahinin dünyadaki öncülerinden birisi. Biz bugün hocanın dediği gibi dünyadaki en iyi eksperleri sizlerle buluşturmak üzere birlikteyiz. Bu akşam da bu toplantıyı kendi sahasında en ileriye gitmiş iki tane büyük bir uzmanla sizlere sunacağız. Viktor Hoca'yı tanıtmaya gerek yok ama Viktor Hoca gerek laparoskopinin, gerek mikrocerrahinin, gerekse mikrocerrahik prensiplerinin dünyadaki bütün meslektaşlara hem öğretilmesinde hem tanıtılmasında hala da eğitimine katkı veren bir insandır. Bugün bizlere reproduktif cerrahinin hikayesi ve buralara nasıl gelindiğini anlatacak. Ben birazcık da İngilizce onlar olduğu için hitap edeyim. This evening we have speakers who are the best in their own area. Professor GOMEL is the pioneer in the field of reproductive surgery and endocrinology. And he himself has also raised many professors. He is the master of masters. It's a great opportunity for us to listen to him talk about his past experience as well as his current studies. I'm proud to say that I was trained by him for a year and a half. So he's going to talk about the history of the reproductive surgery. Buyurun hocam.
It's, the title is Reproductive Medicine. That's what they wanted. So I cannot do the two together. It would have been very long. So I will share the screen now and I will start. Can you see my slides?
Yes.
Slaytlarımı görebiliyor musunuz?
Görüyoruz. Siz geçin bir iki oynatın hocam. Evet.
Evet, müsaade edin de o zaman ben sizi görürsem slaytlarımı göremiyorum. O zaman ne yapalım? Nasıl kaldılar ama ne yapayım? Slaytlarımı görüyorum ama parçalarını göremiyorum çünkü hem kendimi hem Timur'u hem de belki küçültebilirim. Bir bakayım. Yok, ona imkan yok. Attım, dışarı attım. Yok, yine giriyor paşa. Nasıl yapacağız bunu? Tamam. Kapattım. Tamam, oldu. So I am starting. This is the pituitary gland. The anatomy was already evident in 1910. So my title is History of Reproductive Medicine. I don't know how it went back. And as I said, already in 1910, we knew the anatomy of the pituitary gland. So, as you can see, in 1910, already Crow and Cushing and others knew that partial pituitary ablation will create atrophy of the genital organs. So the relationship was already established. And when you took a dog that was puppy dog, very young, again, partial pituitary ablation created persistence and infantilism and sexual inadequacy. We come back to 1926, you can see here that the daily implants of fresh anterior pituitary gland from various animals into immature male and female mice and rats induced precocious sexual maturity, marked enlargement of the ovaries, and superovulation. And here, Zondek demonstrated that implantation of the anterior pituitary glands from adult cows, bulls, and humans into immature animals induced the rapid development of sexual puberty. So you can see that ovarian and testicular function was regulated by the pituitary. This was evident by 1926. These people were geniuses. Here you see Zondek, for whom I just talked to you. And this was a real genius, you will see. With Ashaim, he demonstrated that the blood and urine of pregnant women contained a gonadotropic substance, which was coming from the anterior pituitary origin. When injected subcutaneously into an immature female mice, it produced follicular maturation, luteinization, and hemorrhage into the ovarian stroma. In addition, they created a pregnancy test. It was the first pregnancy test which was done with rabbits. In 1929, the pituitary, he demonstrated that the pituitary secretes two hormones and that stimulate the gonads. He called them prolan A and prolan B. And in his paper, he stated, the master hormones that control gonadal sex hormones are responsible for maintaining the species, which was very true. In the 30s, he suggested that blood and urine of postmenopausal women contain gonadotropins. He suggested that prolan A stimulates follicular growth and together with prolan B induces secretion of folliculin. You know, these names are funny to you, but I am going to come. Prolan B, he said, induces ovulation, the formation of the corpus luteum, and the secretion of both lutein and folliculin. Funny names, but look what they were. Prolan A is FSH, as we call it today. Prolan B is LH. Folliculin is estrogen, and lutein progesterone. In 1930, he was able to do this from the hypothalamus to the end. And this genius in 1933 had no longer any job in Hitler's Germany, but he continued later by going to Israel. We continue. 32, HSG extracted from human placenta was found to have a similar effect to LH. It was produced and sold under the name of Pregnil. The product was used to stimulate ovaries. Pregnant mare serum, gonadotropin, was prepared from blood of the pregnant mares collected on the 65th day of pregnancy. In 1938, it was commercialized. Clinical trials demonstrated an ovarian response, but attempts to induce ovulation were inconsistent and failed to produce bleeding and progestational changes in the endometrium. In 41, a two-step protocol was established, the administration of PMSG, or sheep or hog pituitary gonadotropins during the follicular phase, followed by HCG 12 to 18 days later, resulted in secretory endometrium and pregnancies with timed coitus. In 42, they noted that anti-hormones was formed with non-primate gonadotropin extracts in women. So the primates, you can see, are much closer to humans. Then we have Carl Gamzel, who used pituitary gonadotropins, a Swedish person. He extracted gonadotropins from human pituitary glands. In 1958, he published their experience on clinical effects of the pituitary follicle stimulating hormone. And they obtained the first pregnancy in 1962. They also recognized the major side effects of OHSS and multiple pregnancies. The product was marketed and successfully used for ovulation induction for some 20 years until Creutzfeldt-Jakob disease was linked to other problems and it was no longer used. We come to Bruno Lunenfeld, another genius, with human menopausal gonadotropins. It's a very interesting story. In 1945, Donini, who worked in Sorono laboratories, successfully extracted HMG from the urine of postmenopausal women. In 1953, use in hypophysiectomized infantile rites produced increase in ovarian and uterine weights in the females and production of testosterone, spermatogenesis, and increase of prostate size. With human menopausal gonadotropin, the decision was made in Sorono laboratories to start the clinical trial. The need of a large amounts of menopausal urine and development of industrial extraction was needed. So we come to Bruno Lunenfeld in this issue. After his initial schooling in Vienna and the United Kingdom, and while he was doing postgraduate work in Geneva, after graduating from the School of Medicine of the same city, he met Pietro Donini, of whom I just talked, who was a senior scientist at Sorono. Donini invited him to visit their institute and to discuss with their board of directors the possibility of mass production of HMG to initiate clinical trials. Here I will tell you some things that Bruno himself wrote. The year was 1957 and Bruno was 30 years of age. He gave a presentation on the project and indicated the need to enlist 400 menopausal women who could collect their urine daily. So Bruno writes, after my presentation, they all applauded politely, and then the chairman of the board got up and said, very nice, but we are a drug factory, not a urinal factory. He continues, I run out crying. A board member, Prince Giulio Pacelli, came out after him and told Bruno not to despair. Pacelli was the nephew of Pope Pius XII. 10 days later, he came to him and he said, my uncle, Pope Pius has decided to help us and to ask the nuns in the old age home to collect urine daily for a sacred cause. Sacred cause. That, of course, convinced the board of directors immediately to help our research project with money and resources. I later, he says, discovered that the Vatican owned 25% of Serona. Always business. Here is Prince Giulio Pacelli, and here is the Pope. Then a very important role comes to Robert G. Edwards, Nobel Prize winner in 2010. He was invited to attend a congress where several people were present and were talking. Here they are. And you can see Dozier, Thibault, Winterberger were able already to fecundate in vitro the rabbit's oocyte, published in the Academy of Science. And you see others that were contributing, Chang and Austin, Moricard, and Japanese Yanagimachi, and Supar from France. Edwards decided to get into the business of IVF. And here you see the first articles that were published in Nature and in Lancet. The second one with Steptoe. In 1965, with a grant from the Ford Foundation, and believe it or not, the UK, Britain, has never come to help Bob Edwards. It's amazing. One day I would love to give you a talk on Bob Edwards, the man and his science. So during the visit to Johns Hopkins, he confirmed the maturation timing of human oocyte to be around 36 hours, but failed to fertilize them. And here you see Lancet article, maturation in vitro of human ovarian oocytes. And he found out that this was an excellent material to study the desired stages of growth. And as he said, by analogy with oocytes of other species, the human oocytes can be fertilized after their maturation in vitro. Look at the vision, maturation in vitro, which was done several decades later. He already is telling them it could be done. So in order to fertilize in vitro matured eggs, but human eggs, Edwards had to capacitate the spermatozoa. Failing to achieve this at Johns Hopkins, he makes another journey in 1966 to Chapel Hill, but once again fails to achieve fertilization. His interest in oocytes was rekindled by recent concerns on the number of human chromosomes and description of pathologies resulting from chromosomal anomalies. He wanted to work on human oocytes and where to get them. In the fall of '67 in Cambridge, he read about laparoscopy. Probably this was the little book that Steptoe wrote. So he phoned him, and because of time, I will go more quickly. In other words, as you can see, after he told his story, Steptoe agreed to help him. But he was worried, as he said. I was talking in Cambridge. He was listening to me in Oldham. Let's have a try, he said. Let's see what we can do. I promised to call him back. Oldham, that was a hell of a way from Cambridge. My thoughts often strayed to Oldham, but the problems were too enormous. But you know, chance encounters are wonderful. He attends, invited to a conference on gynecology, and automatically it went back. And laparoscopy was suggested for a condition. So people, as he writes, people lolled in their chairs. A distinguished looking man rose to his feet. No, he said, dogmatically. Laparoscopy is of no use whatsoever. It is impossible to visualize the ovary using this technique. I have tried it. It's a gynecological gimmick. There was another article written in the Green Journal by the editor about whether laparoscopy was a gimmick or not in 1992. Edwards thought it was as well. He had not committed himself to Oldham when at the back of the hall, a thick, set, gray-haired man leapt to his feet. And he said that he could see the whole abdominal cavity. You are hopelessly wrong, he said. I carry out laparoscopy routinely every day. So immediately he felt that a man could trust and respect and work with him. So he approached him, as you can see, you know, in the end, they started working together. But I want to show you something. By then, Bob Edwards had oodles of articles published, scientific articles. Look at Steptoe's CV in 1967. There is not much there, as you can see. But he had a vision. And that vision really achieved a lot. Here they are together with Purdy, the nurse who helped them. It's a bad photograph, but that's the only one I have. And they published in Nature, blastocysts grown in culture. In 1972, October, there was the European Congress on Sterility in Athens, Hilton. Bob Edwards, whom I didn't know, gave a talk demonstrating that he had taken a human oocyte, fertilized in vitro, to 5 years growth in vitro. I immediately understood what that meant, because then I used to do a lot of laparoscopy already, and I had started surgical laparoscopy to the extent of having done a tubal pregnancy by laparoscopy a few weeks before. By chance, I met him in the evening. He was talking with a Frenchman. They couldn't understand very well each other. I had to translate. It was past 6 o'clock. He took me by the arm and we went to have a beer. Then I told him that I was capable to obtain human oocytes by laparoscopy, having already doing laparoscopy and surgical laparoscopy. And he told me if I sent him a technician, he would come back or she would come back 4 months later and I could open a tissue laboratory. But my boss thought I was crazy when I told him that this thing was the cutting edge of human reproduction. C'est la vie. So they continued. First they had a tubal pregnancy and then a human pregnancy, which was published in Lancet and was created a bunch of headlines, as you can see. So his role in the business was very, very important, and continuously he worked thereafter. I was telling you that England was not kind to him. All his support came from elsewhere, and he became a professor at 60 years of age. Can you imagine? And at 64, he was retired. So to that extent, things started slowly. Seppala in 1984 had an international survey, and you see the treatment cycles and the deliveries by cycle initiated was only 5.4%. In 85, Jones, who was very active in his department, between 81 and 83, demonstrated 12.3% success rate. But that was deliveries per OPU as opposed to deliveries per treatment cycle. So obviously per treatment cycles, it would have been less, as you can see. And this is in our department. We started it a little late, but we were there. And you can see that 84, 85, we had 11.4%, but they were oocyte retrieval cycles. And when we look at the national registry, which comes much later, 85, 86, you see around 11% birth per embryo transfer. So that if you look at by treatment cycles, it would be quite less than 10%. It would be something like maybe 6, 7% maximum. And what I want to show you that there were very few cycles done. In 1970, I would like to remind you, reconstructive surgery was the only realistic option for the treatment of infertility that was caused by tubal and peritoneal factors. This was to remain until early 90s, when the rate of live birth per initiated in vitro fertilization cycle reached 12% in the USA. We won't do that, no time. So here it is, 12.3% in 1990. During that decade, that doubled to 25.4. And in the meantime, we see people doing subzonal sperm insertion, SUSI, to increase the pregnancy rate or the implantation rate or fertilization, whatever. But once the needle went too far, and that became ICSI, it was an accident. they were able to publish early on when the pregnancy survived. They were able to, in the interim, to do some animal experiments and see that it worked. And ICSI became very famous and much used. You can see that at the end, we reached a plateau of around 28.5 to 30%. And this decreased terribly surgical intervention for infertility. We had our first baby in December, Christmas Day, 1983. So, I mean, I was never against IVF and would have started it if I had permission from my boss and not wait for 10 years till I became head of department. The success was largely, in those days, you see, 1912, by using too many embryos. You can see on days 3, which a lot of the cycles, you know, were terminated on day 3 and the embryos introduced. You can see, sorry, whenever I move, you can see that 2 embryos were the majority, 1 embryo, very few, and then you can see 3 embryos, 25%, 4 embryos, 33%, and so on at various stages. And the same happens in 2014, maybe a little less. You can see that 2 embryos is over 50%, and 1 embryo has increased to 23.6%. Nonetheless, here again, you can see the started cycles and the outcomes in singletons in white and twins in red and the rest. And we know that even twins and triplets have a lot of problems. Preterm birth, low birth weight, as you can see in the various colors. We also know that multiple births have increased obstetrical complications, increased neonatal complications and deaths, and are responsible for major societal costs, significant financial burden, and emotional costs for the parents. In those days, when we looked at delivery to cycle initiated, it was around 28.5%. If 3 cycles were initiated, we would be under actually 50%, although mathematically it becomes 54%, but further cycles usually were less productive. In any case, we also knew at the time that several studies were conclusively shown that the majority of couples undergoing IVF-ET do not wish to complete 3 cycles of IVF. And this was even true in France, where IVF was paid by the government. The couple did not need to spend a penny. So, fortunately, prenatal genetic diagnosis started, which permits couples at risk or having progeny with congenital anomalies to have normal and healthy children. This was the initial selling to do genetic testing. So Then embryo biopsy started to test chromosomes and or DNA. If there was normal, the embryo was transferred. Otherwise, embryo was discarded. And to conclude, I can tell you the gold standard today. The gold standard is today delayed transfer of a single blastocyst stage embryo classified as normal, euploid, by pre-implantation genetic testing with the objective of obtaining a single healthy pregnancy at birth. So this permits you to have an embryo at blastocyst stage which is normal and with the implantation only a single embryo. Ladies and gentlemen, thank you very much for this privilege.
Thank you very much, Professor GOMEL. And we talked to you just before deciding this lecture. I think you could say something about that, because if you don't know the past, you cannot go to the future. What do you think about that? Because, you know, now...
If you don't know the past, you don't understand the future.
Yes, you cannot go. But the important thing is just, you know, nowadays, lots of people, our colleagues, are just thinking everything was the same for the lifetime. So I remember in my life, and I have to acknowledge Professor Kishnishji, he was bringing some ampoules of Humagon from UK or USA, giving us every 4 days to make a half injection. So it's you know, so we didn't know anything about that. But we haven't seen the real-time ultrasound, and you are just talking about the Aşem Zondek test and with the frogs, you know, you know.
No, the frogs is Galli Magnini. That's Italian. Zondek is with rabbits.
Rabbits, yes, the Galli Magnini, and I can remember a guy name is Shinasi. He was just collecting the, you know, frogs in the lab of the department and just injecting some urine, and sometimes you see the whatever.
I remember also when I came the first time to Hacettepe, they thought I was a stranger. And at Hacettepe, in addition to giving a lecture, I had to demonstrate laparoscopy and do sterilization.
Yeah.
And I can tell you, if you want, after my friend talks, I can tell you a very interesting story.
Okay. Thank you very much, because, you know, we have to move to another leader, and everybody knows him because he's a kind of the leading person, or we could say that when you think about the ovulation induction in PCO, and everybody knows the Roy Hamburg. He was the leading person. Thank you very much, Roy, just being with us, because, you know, and it is the same. I think you could say some words about that, because we think we knew the PCO, but for the years, and we think we know, but just now, even if we don't know too much. Okay, he will be talking about an enigmatic disease.
Duyuyor musun? Hala Zoom meeting'deyim. Neyse, ekranı kapattım.
Okay, so sen görünmüyor musun orada? Recai, resmini çıkar, gel konuş. Göremiyorum
Timur,
seni.
benim bir görüntü problemim var. Ben hepsini izliyorum. Sen devam et. Görüntüyü halledemiyorum.
Okay, sorry for that. You could make the closing ceremony. Okay, Roy, and please go on. Tell us what's going on in PCO and the diagnosis and possibly treatment of the PCO. Thank you very much.
Thank you, Timur. First of all, I'd like to thank you very much for the invitation. It's a privilege and a pleasure to be able to talk in this kind of meeting. It was also a great pleasure to hear Victor talking now. I've thoroughly enjoyed the lecture, and especially I heard about my old boss from 1972, and that was Bruno Lunenfeld. And it's because of Bruno and Professor Insler, they worked together, that I carried on in the profession that I've been doing ever since. So thank you, Victor, and thank you, Timur. So we're going to talk about some recent advances in the understanding and treatment of PCOS, and Timur is exactly right. There's still a long way to go before we understand everything. PCOS is not new. It was, would you believe it, first described by Hippocrates so long ago. And he said, but those women whose menstruation is less than 3 days or is meager are robust. They have a healthy complexion and a masculine appearance. They're not concerned about bearing children, nor do they become pregnant. Little was said about or described about PCOS until those wonderful people, Stein and Leventhal in 1935, who described 7 patients with polycystic ovaries. They had amenorrhea, infertility, a masculine type hirsutism, and some of them had obesity. This was really the first description of what we know today as PCOS. And the treatment they suggested was wedge resection of the ovaries. Then it produced many ovulatory cycles and many pregnancies without people understanding why. And I think it's really only today that we now understand how successful this operation really was and why it worked. But more about that later. The next big step was making a consensus. The Rotterdam Consensus in 2003 stated you needed 2 out of 3 criteria to make the diagnosis of PCOS: oligo and/or anovulation, hyperandrogenism, which could be clinical or biochemical, and polycystic ovaries. The description of polycystic ovaries then was more than 12 small follicles. This today has been updated because of the improving resolution in the ultrasound machines to more than 20 small follicles to define a polycystic ovary. Now, 1 in every 5 women has polycystic ovaries, but half of these only will actually suffer from symptoms. So it's a very common condition. I can't tell you which one of these 5 actually does have PCOS, because that, of course, would not be ethical. Where does it come from? Well, we know that PCOS is strongly familial. But for 20, 25 years, we've been looking for the gene or genes that have a polymorphism that maybe causes PCOS. We've never found it. So this suggests to me that the inheritance is modified by environmental factors. And it's very possible that there is reprogramming of these particular genes in utero. Now here we're talking about the Barker hypothesis, which is really the developmental origin of adult disease. And what the Barker hypothesis says is what happens to the fetus in the pregnancy and its environment can very much influence what happens to its health in adult life. So the question was asked, can exposure of the female fetus in utero to high levels of testosterone cause PCO in adult life. David Abbott, a friend, a veterinary surgeon who works in Wisconsin, gave high doses of testosterone to pregnant monkeys. When the female babies grew to adolescence and to puberty, they were examined. And the babies, the adolescents whose mothers had been injected with testosterone, produced an adult PCOS phenotype compared with the controls that were just injected with pure oil. They had high LH levels. They had a polycystic looking ovary as we know it today. They had anovulation or oligoanovulation. And surprisingly, all these monkeys developed metabolic consequences. They had insulin resistance. This was a remarkable result, and it led to the developmental origin of PCOS, which David Abbott and colleagues put together, and which I'm going to talk about today. The prenatal exposure to androgen produced a polycystic ovary, a central adiposity, high LH secretion, and insulin resistance, anovulation, and hyperandrogenemia. So what had obviously happened here from these high exposure to androgens was that the genes regulating folliculogenesis and steroidogenesis and the genes regulating insulin secretion had all been reprogrammed by high testosterone levels in utero. Now, where are these androgens coming from? It could be from the mother because women with PCOS in pregnancy have high levels of testosterone, but testosterone does not cross the placenta. So this leaves us with a question. Are these high levels of testosterone coming from the fetus? Well, this is highly unlikely because both the fetal ovaries and the adrenals are remarkably inactive during the pregnancy. So this was a puzzle. And Malikeo, some years ago, I think gave us the answer because he thought that it was coming from the placenta. And he actually showed that anatomically and histologically, the placenta of PCOS women was quite different from those of women with no PCOS. And in particular, the hormones, the enzymes that promote the testosterone production in the placenta were markedly increased in women with PCOS. So the first thing to do to prove this hypothesis was to show that the fetus actually was exposed to excess androgens in women with PCOS. At first, I designed a study of amniocentesis, but had to give up this idea because so few women with PCOS have an amniocentesis these days. Several groups, including ours, had a look in cord bloods whether there was excess testosterone. And this produced a multitude of different answers, not completely surprising, for two reasons. One, because there's an enormous range of androgens in cord blood. And two, because immediately before delivery, as you know, there's an absolute explosion of endocrinological events. So this did not give a true result. So I had to look for a surrogate of androgens to demonstrate this in the newborn. And I decided that we would look at the sebum production of the newborn. Why? Because sebum excretion rates are 99% directly correlated to androgen levels. As we've said, the androgen concentrations in pregnant mothers with PCOS are high when compared to those without PCOS. So if PCOS mothers expose their fetus to high androgen levels, then the sebum excretion rates will be higher in those neonates born to mothers with PCOS. So the hypothesis was significantly higher seborrhea in the neonates of PCOS mothers would lend credence to the whole hypothesis that excessive in-uterine androgen exposure programs target tissues undergoing differentiation to develop the PCOS phenotype in later life. We did the experiment measuring sebum in the neonate within 24 hours of the delivery. And the results so far that we published in the pilot study in the women who were pregnant with PCOS, 6 of the 9 neonates had high levels of sebum compared with 1 out of 12 in the controls. When we correlated these results with the maternal testosterone, you can see there was quite a distinct relationship between the amount of sebum secreted and the maternal testosterone levels. So there are implications, I think, to this sort of research. The daughters of mothers with hyperandrogenemic PCOS are exposed to excess androgen levels in utero. And the question is, does this increased skin greasiness in the first week of life predict subsequent development of PCOS? Now, if so, and I could tell you within 1 day of birth that this particular baby in its adult life would develop PCOS, this has an enormous number of ramifications, as particularly regards prevention. Let's move on to AMH and PCOS. Anti-Malarian hormone, as we know, it's expressed in the preantral and the small antral follicles. So it's no surprise that in the polycystic ovary, which has such a large number of preantral follicles, that the AMH is always high in PCOS. These serum AMH concentrations are quite capable of differentiating between normal ovaries, ovaries with just a morphological appearance but no symptoms, and full-blown PCOS. And this suggested to us, and this we examined, that the number of small follicles in the ovary determines the severity of the syndrome. Now, this was verified by Didier Dewayer's group a while ago now, and he looked at AMH levels in PCOS women with regular cycles, oligomenorrhea, and amenorrhea. And you can see quite distinctly that the women with the largest disturbance of their menstrual cycle and ovulation had by far the highest amount of AMH which was circulating. Now, the reason for this is that the action of FSH that promotes follicular growth is counteracted by AMH. So this is a very obvious cause of the anovulation of PCOS, something we hadn't realized before AMH was measured. So in PCOS, you have an excess of androgens, multiple small follicles producing large amounts of AMH, which inhibit the FSH action on the follicles, the production of aromatase, and thus produce anovulation. A wonderful paper, again from Didier Dewayer's group published a couple of years ago, first of all showed that the AMH was higher in lean pregnant PCOS women compared with obese pregnant PCOS women. Now, the lean PCOS women are those who have the high LHs. They went on to do experiments in pregnant mice whom they injected with AMH. And AMH produced high amounts of testosterone in the mother. The placental metabolism of testosterone to estradiol was decreased so that the testosterone went up distinctly. And these pregnant mice produced babies that had a PCOS phenotype in adulthood. So AMH, when injected, did the same as testosterone in producing PCOS in the adult. Further, they went on to show that AMH stimulated GnRH neurons to induce an increased LH pulsatility. So now we also have an explanation why LH is high in many of our cases of PCOS. This is something we've put together. It will be published in the new year, where we try to explain the relationship between the hormones involved in PCOS pathogenesis in the maternal environment, the fetal environment, and in puberty. I'm not sure we've got it 100% right yet, but I think we're on the way. Now, let's summarize this part and say the exposure of the female fetus in utero to high levels of testosterone probably causes PCOS in adult life. The severity of symptoms of PCOS is positively related to the number of small follicles reflected by AMH, and the AMH may also play an important part in the pathophysiology of PCOS. Let's move on now, if we're talking about advances or new developments, the first-line treatment of anovulatory infertile PCOS. Weight loss in the obese and overweight is a must, but then we have the alternatives to induce ovulation of clomiphene citrate, letrozole, or the insulin-lowering medications. Which is the best? Well, letrozole, since it was introduced, certainly has shown theoretical advantages. It doesn't block the estrogen receptors as clomiphene does, so there's no detrimental effect on the endometrium or on the cervical mucus. Also, using letrozole, the negative feedback mechanism is not turned off, so there is less chance of multiple follicular development. If we explain that further, when clomiphene citrate eventually produces estradiol from the ovary, it gets to the hypothalamus and the pituitary, but the estrogen receptors are blocked so that the FSH production cannot be switched off. And this with clomiphene may well predispose to multiple follicular development. Whereas with aromatase inhibitors, there's no problem with the receptors of estrogen on the hypothalamus and the pituitary. So that when the estradiol level goes up, then the FSH can be switched off, and there is a much less chance of a multifollicular rather than a monofollicular ovulation. So it was no surprise that in one big trial done by Rick LeGros, that letrozole, as far as live births was concerned, came off significantly better than clomiphene for the induction of ovulation in a large number of patients with PCOS. The inevitable mega-analysis was done in 2015, showing the same results, that letrozole was superior to clomiphene for live birth and pregnancy rates in patients with PCOS. And this is the latest meta-analysis, not yet published, that does show, again, an advantage over letrozole, over clomiphene, as regards live births. So I think this today is an established fact that letrozole is the first-line treatment of anovulatory infertile PCOS. The women with PCOS significantly more likely both to ovulate and to have a live birth after using letrozole rather than clomiphene. The incidence of live birth is increased by 40 to 60%, and resistance is lower with letrozole versus clomiphene, and the multiple pregnancy rate, which we showed theoretically, do indeed appear to be lower with letrozole than with clomiphene. What about PCOS in IVF? And here I think in the last few years there's been a great advance. I like this quote from Paul de Vruij it's nearly 10 years ago now, and he said that nowadays ovarian stimulation strategy is a beautiful example of lack of intellectual precision in the process. The treatments are long. The HCG for egg maturation is still the gold standard, and the occurrence of 3% of severe OHSS was well accepted. So this was really uncontrolled ovarian stimulation rather than controlled ovarian stimulation. Well, I'm glad to say, Paul, that in these 10 years, we have advanced a great deal. The biggest problem was the high responders for IVF and the incidence of OHSS. And of course, PCOS is mainly responsible for this because they produce such a large number of follicles, and this predisposes to OHSS. And after all, OHSS is an iatrogenic overdosing on gonadotrophin stimulation, and it is totally preventable. So the secret of the management of PCOS in IVF is to anticipate which women are likely to fall into this category. Then we can adjust the starting dose, the stimulation protocol, and the ovulatory trigger. So if you want to avoid ovarian hyperstimulation, first of all, know your enemy. Then do not overstimulate. And thirdly, avoid using HCG as a trigger if you're at all suspicious about the onset of OHSS. We use AMH in order to predict the truly high responders. This diagram, first done by Scott Nelson and Richard Fleming, shows using AMH to decide which protocol you're going to use. Now, this is just a suggestion, but you can see as far as the high responders are concerned, there are definite strategies which are dependent on the level of AMH, certainly in the first cycle of IVF and ovarian stimulation. These are just suggestions, but really every department should decide what is its cutoff for AMH to predict high response. Once you know this, you've won half the battle. Always use an antagonist in PCOS IVF cycles. Why? It's a shorter duration of stimulation. Less gonadotrophin is required. The OHSS incidence is distinctly decreased. And importantly, the discovery, I think, of the last few years is that an antagonist protocol allows the use of an agonist trigger. Why is a GnRH agonist trigger better than HCG? First of all, it produces an endogenous L8 surge, which is similar to in a natural cycle. It has a smaller amplitude than HCG and a much shorter half-life. And importantly, it releases less vasculoendothelial granulosa factor than HCG. And this, of course, VEGF is a very important factor in the pathogenesis of OHSS. The problem is, of course, is the luteal phase support. And the way we have found most successful is using Peter Hoemeiden's idea and giving a very small amount, 1,500 units, on the day of pickup, which of course is a few days after the GnRH agonist trigger. We have found that the results are excellent as far as live birth is concerned, but it's not completely foolproof. We had a very low incidence, about 0.2% of OHSS, but it's certainly a vast improvement on the previous protocols. The best advice of all, of course, is if you have a large number of follicles, you're anticipating OHSS in these high responders, freeze all your embryos and replace them one by one in a natural cycle. Each unit should decide what is its cutoff point for AMH in order to freeze. Ours, as you see, is 25 follicles, but we've been much more lenient lately, and we're much more inclined to freeze all our embryos, certainly in women with PCOS. So again, using AMH, this is our particular protocol for treating PCOS in IVF. Segmentation of the IVF cycles, first suggested by the Brussels group in 2011, is the way to go in these patients. Optimization of stimulation in an antagonist cycle using an agonist trigger, vitrification of the embryos, replacement in natural cycle with or without endometrial preparation. The last big step forward I want to talk about is the publication of the ASRM ESHRI guidelines for polycystic ovary syndrome. These for anybody dealing in our profession with PCOS in IVF and any treatment at all of polycystic ovary syndrome. It's all in there and it's all been evidence-based and well worth a read. So I'd like to thank you again for this privilege and pleasure of talking in this symposium. Thank you again.
Thank you very much, Roy. I think we are just concentrating especially the pathophysiology of the PCO, and we are just talking about the high androgens, and we are going to back to the uterus. This is the very important thing. The another thing, it is very interesting, having the information that we could get some information from the newborn, and we could, if she's going to produce the PCO. The another important thing is just we are having some very important information about AMH, for the pathophysiology. For the treatment, and you already mentioned, I think the main problem is to prevent the ovarian hyperstimulation. This is the main goal, and we have lots of some things in our hand. So we have some. There will be no zero, hyperstimulation, but we have to consider not to make our loved ones too much ill. This is the things. So we are having now something like the record, followers for our webinar. This is just giving me the information that it is something like 325, colleagues are just following it. But we are just, I'm just really asked our colleagues to ask some questions, because, it is not only the everything is not just what you said. So there are something. So, and I think you know the Hikmet Hassa, but you know, I'm going to go to the Recai. Just he could say something about the lectures, my co-chair. So, you know, the Hikmet Hassa is just saying to, you know, Victor and the Roy, because he's very happy to hear you, to see you both. He said that he missed you a lot because, you know, Hikmet Hassa was one of the leading person, you know, and he was just educated, trained in Hacettepe University. And after they went to Eskişehir to set up the new clinic. And he was one of the pioneer of the laparoscopy in Turkey, right? And Victor was with him too. So thank you very much. So, and Melahat Dönmez, professor, is just saying that thank you for excellent presentation and nice slides. And Engin Oral is just saying, what's your opinion about the laparoscopic ovarian drilling? So I was going to say something, but okay, because you are just both expert about that, we could start with Victor. And we remember the old days where we are just against any kind of intervention to the ovaries because we thought that we increase the adhesions. What do you think now?
But I've done a lot of ovarian drilling, but I did it very gently.
Yeah.
Without adhesions.
Yeah.
No, honestly, look, you know, every intervention in the peritoneal cavity can destroy or can do very good things. It's all technique. By the way, I enjoyed very much Roy's presentation. It was superb and comprehensive. Lovely.
So, Roy, I think, you know, I want to share some information with you because it is going to help the question of the Professor Engin Oral. He is just the chairman of the Turkish Society of Endometriosis. But
also.
Yeah, but the important thing is just, we were just thinking, making some, you know, holes on the ovaries, just working, and we thought that it was the decreasing the androgen levels, but we couldn't explain it. And I have some, please tell it, I have an idea. We are just having some data I want to share with you. If you would like it, we could carry on, right?
Yeah. Well, I'm a great fan of laparoscopic ovarian drilling, and it's exactly as Victor says, it's like any other procedure. If you do it properly in the right people, then it works extremely well. Secondly, as regards how does everything happen? Well, we examine this very carefully. When you do laparoscopic ovarian drilling, you do something very similar to what Stein and Leventhal did in 1935. You're chopping out, you're deleting a large number of follicles that are producing AMH. Now, as I've shown, large amounts of AMH inhibit the action of FSH to promote ovulation. So if by removing these follicles that are producing these high amounts of AMH, you're reducing the amount of AMH and allowing FSH to stimulate the follicles and produce ovulation. So now I think we've got a very good explanation of why both wedge resection and laparoscopic ovarian drilling works.
Yes, thank you very much. So we are just having some additional information about the disruption of the hyposignaling. And something like, you know, because we know that with some cases, with the menopausal or something, some ladies with the decreased ovarian reserve, if you make a kind of, you know, small operation like the putting the cortex out and after that mincing them into the pieces and putting it inside. And there are some publications from Japan and also from USA, and we did something like that. And they think that that, you know, they could reactivate the ovaries and start to make the ovulation. So, and this is something that we have some data, but I reverse it to the PCO cases. So I'm going to talk about that. Disruption of the hyposignaling, reactivate the, you know, ovaries of the PCO cases with some special treatment. Okay, Recai.
Yes. Yeah, if your permission, I want to ask a question to Roy. So Roy, it was fantastic presentation. Thank you very much. You summarized everything. So my question is about, again, drilling. To which cases do you advise to go to drilling? Separately, please.
Okay. First of all, they've got to be clomiphene or letrozole resistant. And the cases with the best prognosis for laparoscopic drilling are those normal weight women with PCOS who have high LH levels. These are the cases that do really well, not the very obese and not those with extremely high testosterone. But if they're of normal weight with high LH, they'll do extremely well with laparoscopic ovarian drilling.
Okay. Our information about the clomiphene resistance cases is about 20%. What about letrozole? What is the percentage of the letrozole resistance PCOS patients? We have no idea.
Yeah, it's less than clomiphene. It's somewhere between 15 and 17%.
Okay.
So, and there is a question from, you know, Emre PABUÇCU is saying that appreciation for the nice lectures. My question is to Dr. Homburg, for ovarian stimulation for IVF, what are the pros and cons of combined FSH and HMG in anticipated high responders?
Sorry, what are the doses?
What are the pros and cons for FSH? And so it means the recombinant FSH versus SMG.
Yeah. Well, there was a very good study done in Lausanne in Switzerland that examined FSH versus FSH plus recombinant LH, FSH versus HMG, just about every possible combination that you can have. And if you're just looking at live births, there was absolutely no difference. And I've been convinced for many years, certainly for PCOS, it doesn't make any difference which preparation you use for ovarian stimulation. The only difference is if you have LH in your preparation, you may get slightly less follicles developing, especially among the small or intermediate size. But as far as live birth is concerned and ongoing pregnancies, you can use any preparation you like and it doesn't make any difference.
Another question is, what is the criteria for bariatric surgery for PCOS? Is it effective for fertility?
Yes, it's a difficult decision to make because it's such a difficult operation. But for those with PCOS and who are infertile and have a BMI of 35 or over, then we offer them the possibility of doing bariatric surgery, and it works. It works well. Okay, so there is a question for Victor GOMEL, and they
he thanks you a lot because he agrees that he says a professor is saying that, you know, they agree that we have to know the past. But what do you think for the future? Is going to be more easy to make any kind of treatment for the fertility treatment, like the you know, they're using the computers like or the automata laboratories. So
I mean, there is a lot of things coming on. You know, if we can have cars that go without a chauffeur, you know, artificial intelligence may exceed us, because they won't have the same. You see, when you do something as a technique, not by a human, it's always the same. So there is no difference in competence. So things will improve as we are so surprised with the things that we see today. So, you know, technology will improve. The only thing, unfortunately, that is not improving is the human beings. You know, when you look at the Sumerians, who were 6,000 years ago, and who had to our knowledge, the first writings, and people read them, just we read a book, you find out that the human being in 6,000 years has not changed. It's the same. We fight, we have genius, and we have terrible things. We use our genius negatively. So the important now is for us to improve also.
Okay. Timur, ben bir sorayım. My question again to you, Sayın Hocam. Sorry, I had a screen problem and I couldn't find any solutions. Only I can hear you. That's all. What is the future of the uterine transplantation? What is the current situation and the future situation?
Look, I have written a even if I say so, I have written a very good article, good in the sense that I didn't take any sides. But you know, to subject a donor to such a terrible surgery, you know, I'm calling my only problem with the uterine transplantation, you know, and I didn't speak about surgery today. You know, I was confined to medicine. I would love someday to speak about surgery, because surgery is becoming mistress. So, when you take a live donor, the surgery that is done on the live donor is so extensive that it really destroys that person's life. Look, why instead of a mother who is giving her daughter a uterus, most of them, when you see them, are under 55 years of age. And when you look at ASRM says if the woman is healthy, she can have an embryo inserted until age 55. I assure you that if the woman wanted to carry the baby, it is much easier for her and less intrusive, less harmful than having that operation. So that's one option. The other one is a friend can carry it or somebody can carry it with money. So it's a pregnancy. So, or, and when, funny enough, when I wrote the article, it was about 2.5 years ago, I talked about the possibility of using cadavers. Then it is only the person who wants to have a uterus that is submitted to surgery. So nobody else is involved. Nobody else is hurt. But when I wrote it and sent the article, they had tried cadavers, but there was no success. After the editor received my article, 3 days later, there was an article in the Lancet that there was a case with cadaver, a woman delivering a baby. He sent me the article back and I was able to include another chapter, but a paragraph there citing the reference that there was success already with a cadaver uterus. So, I mean, if it is with a cadaver uterus, it's fine. If people permit other people to carry their baby, because in many places this is possible, I can tell you that in Vancouver, someone wanted to have 3 boys and all carried by, what do you call it? People who would carry the baby, pregnancy.
Surrogate.
Yeah, surrogate. So that was done. And, you know, we have 3 boys, a week or so apart. Wonderful. You see, I mean, we have to look at you see, in my life, even with surgery, when I was very young, why did I get involved in adhesions? It's because in those days, they would operate a patient to, you know, there was a lot of sexually transmitted infection, lots of cases to do surgery, and they put some, after, you know, I would operate with the doctors. I was a resident. There was only adhesions in the pelvis, down and around the ovaries and so on. So we would remove the adhesions, open the tubes, and put a little plastic in there, tie it, and then we had to go back 3 months later to remove them. And what I saw when we opened the belly on the same patients, not only there was adhesions in the pelvis, the whole abdomen was adherent. And we had to do a tremendous adhesion lysis before we even got to the pelvis to remove. And I realized that, you know, the surgery was damaging rather than helping the patient. This is why also the success of pregnancy was very little. So I don't like to hurt people. If a patient wants a uterus, fine. If he gets it from a cadaver, it's fine. It's only her that she is being operated. So that's where I am at.
Okay, thank you.
Thank you very much. I think to Roy, so we are just blaming the high AMH, right? There are some, studies on just finding out the solution to antagonize or to decrease the AMH for the treatment. Can you say something about that?
Yeah, there is an antibody to AMH, but I certainly haven't seen any clinical studies that employ this. And I think it's pretty unlikely that we'll see this in the near future. On the other hand, if the whole idea is to reduce testosterone levels in the mother during the pregnancy, then this is a very easy option. Because even things like metformin or myoinositol reduce testosterone during pregnancy. Whether this will be enough to make a difference or not, I don't know. But we're doing the trial and I hope it will show something.
Yeah, this is just, we have to think about inositol, myoinositol, because there are some publications are coming showing lots of areas that this drug can help. But it is something, we have to have some more data about that, because if you listen a lecture about this drug, you could say it's a remedy for everything.
Yeah, it depends whether the drug company that's producing it is giving the lecture. And this is always a problem.
Yeah, okay. So Recai, soracağın bir şey var mı? Göremiyorsun veya söyleyeceğin bir şey. Sonra istersen artık epey geç oldu. Kapatalım.
No. Yeah, I want to thank you to both speakers. Thank you very much. So everyone is listening to you, and then everyone was very happy. Thank you very much for your contributions to our society of our meeting.
I think we should thank the participants.
Yeah, we will do it at the end. Yeah. I will. Okay. First of all, we want to thank you, Dr. GOMEL. You are the leader, and you helped to Turkey as a scientific person and also as a philosopher, as a the AB, and also the friend, and you supported all of us, not the person, only the individual, to improve the quality of the information and the education in Turkey. And I want to thank you on behalf of my society and on behalf of everybody who is working in the reproductive medicine. And I think this is the same, Roy. You are a good friend, and you are all the time helping to the people and having lots of ideas in your mind and trying to, help to patients and the individual and the human beings. Thank you very much. I think we are we are just going very speedy in the science, and also especially in the technology, and especially we are putting lots of information about the human molecular genetics. It is the future, because nowadays we are using the artificial intelligence, and maybe we don't need too much people, and also we are adding something like the human genome editing. We could edit the genome now, but
slicing.
Yeah, but the important thing, because I want to ask Dr. GOMEL and Roy to say some last words or the sentences, because I know that Victor is very sensitive to this kind of things, because he is all the time, we remember what he said in in his one of his book, saying that if we could do something scientifically or technically, it is not mean that we are going to do it, because it should be the beneficial for the humankind. Because, you know, sometimes we are doing lots of things, we don't know who is going to use it. Sometimes it could be used by the not good hands, and it will be the bringing the end of the human kind. Okay, so Roy, can you say something to close the, you know, the webinar?
Yeah, first of all, I've thoroughly enjoyed it. It was a very nice way of spending an evening. It was good meeting you. It was splendid to hear Victor, and I appreciate the invitation. A word about science. Science will always progress. And it's exactly as you say, it depends what we do with it. So it's very much a human decision. And two things may spoil this progress in the science. One, as Victor has said, if it's used wrongly, then this is bad news. So there has to be strict regulation. And two, if bad science is used for purely commercial purposes, this is also not good. And I'm afraid, certainly in the IVF field, this is being done today. And I think this should be more based on evidence-based medicine rather than just trying to make money from the patients.
Thank you very much. Victor, you close the session.
I close the session. Look, first of all, I won't say anything philosophical. We have already gone through a very unusual times with COVID. Everybody is tired. Everybody is trying to save themselves for not getting the virus. You have the experience going through. And I had the good fortune to be 1 hour away from you so that I could talk with you a few times a day. So look, let's look at the sunnier times with the vaccine, and let us become better human beings and help others and not just worry about money.
Thank you very much. Money
Timur.
is not important.
You see,
love is important.
I will tell you a sentence I used 45 years ago in my first book on microsurgery in gynecology, and that was André Gide's sentence: tout ce que tu ne sais pas donner te possède, which means all that you cannot give possesses you. You have to give. You have to give to your students. You have to give from yourself. You have to give money to help people, and you have to give knowledge.
Okay.
Timur, son sentence, Timur. So last sentence from me. Happy New Year's to all.
Okay,
You forgot.
Okay, so there is nothing to say because we did everything. Thank you very much for all of the people who are following us by now. And we will continue. Thank you very much for our friends. And we are just saying, saying that, you know, Merry Christmas. It was just a few days ago, 21st, and the Happy New Year.
No, 21st. It starts tonight.
It's okay.
Yeah, and tomorrow.
I'm sorry, because we don't have this kind of things, you know. We have we have
New Year.
Do you have the turkey? Just eating? You will have turkey to eat? No. Okay. Good night. See you soon. Be safe. Be healthy. Bye-bye.